So we are joining with the next MCQ session in our MCQ discussion series. Today we are planning to discuss a few single best answer questions. Right. On question 29. So focus on question 29. I have highlighted the important words or statements in the MCQ. So the first question is 75-year-old woman with total dysphagia was diagnosed to have mid-esophageal carcinoma. She had ischemic heart disease and bronchiectasis. She could walk only few steps without support. What is the most appropriate intervention? So while considering the patient's condition, so 75-year-old, relatively old female, total dysphagia means even it is the dysphagia is there for even a bit of saliva. And then mid-esophageal carcinoma is somewhat something in advanced stage. It infiltrates into the carina, trachea, and the sometimes pericardium or the cardiac muscles even. So it is bit difficult for resection, but not all the cancers. Even after neoadjuvant chemoradiotherapy, it can be resected out. But mid-esophageal carcinomas are a bit difficult for surgical interventions. And then she had ischemic heart disease, bronchiectasis, and she could walk only few steps without support. That means that the patient is very fragile. So then the patient is having a medical conditions. So she has debilitated with all of that. So she is not a good candidate for a surgical intervention. So in that side, that type of a case, the treatment is totally target on the palliative care. So the most appropriate intervention for this one, endoscopic stent. Yes, it is true. Peg insertion. So for the peg insertion, we should have access to the stomach through the endoscope. So if the patient is having total dysphagia, the thing cannot be possible sometimes because we would be able to pass the endoscope through the lesion for that type of intervention, and the peg tube also having some diameter which is less than the however the endoscopic diameter, but the plunger the bumper is there at the end of the peg tube. You may have seen that. So it has to pass through. So to pass through that, it should need some sort of a diameter or some sort of a space in the esophagus. So I don't think the peg insertion therefore would not be practical in this situation. Esophagectomy out because it's a major surgical procedure. With this condition, I don't think the patient would be tolerate that side of radical surgery. So the endoscopic resection, yes, it is also a palliative care, but not available in our country. So the neodymium yttrium aluminium garnet laser resection can be done for this type of patient, but it is not widely available in Sri Lanka. So neoadjuvant chemotherapy is neoadjuvant chemotherapy means so after the neoadjuvant chemotherapy. So if you are planning for surgery, so this patient is not a candidate, as I told you earlier, for that type of procedure. So that answer is also out. So we are left with endoscopic stent and endoscopic resection. So here it is not, if since it is not widely available in our part of the country, and endoscopic resection also can lead to various complications. So this patient, I think, the best answer is endoscopic stent. So the stent placement can be, even though it is the lumen is completely obstructed, we can put a guide wire and we can do some endoscopic dilatation through that. With that, we can put an endoscopic stent to this patient. So I think the answer is A. Then we move to the question 22. A 40-year-old consumption of alcohol regularly. Then this time presented severe bouts of vomiting, but in the last vomiters associated with blood after ingestion of alcohol, and is hemodynamically stable. What is the most likely reason for the presentation? So this is a typical example for a malarious tear. So malarious tear develop not essentially need to be the alcohol consumer, but even after repeated bouts of vomiting, when patient vomit or when patient is having the retching, Due to that type of efforts, the gastroesophageal junctional mucosa can have a tear, so which is having very high blood supply to that area. So the patient can present with frank blood in the vomiters. So the patient can vomit a significant amount of blood with that, but it is self-limiting. It settles at its own most of the time. Sometimes, very rarely, we need surgical interventions for that also. And the patient is fairly a young guy, a 42-year-old. So even though the patient is continue to have alcohol regularly, it is very rare to develop cirrhosis and esophageal varices. That is in the advanced stage at this type of a young. So esophageal varices, even though is a possibility, here it is bit uncommon because it has clearly mentioned after several bouts of vomiting, but in the last vomiters associated with blood after ingestion of alcohol. So the gastric cancer out, gastric erosion, peptic ulcer, those are even possibilities, but not in this case. So repeated vomiting after repeated vomiting, the answer is E, that is Malariasis syndrome. Then we move to the question 23. A 60-year-old male underwent anterior resection for a rectal cancer. After 5 days, patient complained of abdominal pain and distension. And on examination, pulse rate was 120 and the blood pressure was 80/60. Respiratory rate was high, not pale, and significant abdominal tenderness in the lower abdominal area. What is the next investigation to come to a diagnosis? What is the next investigation? So, as we all know, after anterior resection, we go for a colorectal anastomosis. Most of the time in these days, it is staple anastomosis. Even we can do hands-on anastomosis, but more or less has the equal leak rates. So above the peritoneal reflection, 4% of the leak rate is there, but below the peritoneal reflection, the leak rate is 16%. Even though the patient, if the patient has had neoadjuvant chemoradiotherapy, still the leak rates can be high, more than that percentages even. So, and the typical day uh, for a leak to happen is after 5 days time. So that is 5 days. That is typical for a leak to happen. So then we considering the picture of this question, the patient is having an anastomotic leakage. Possibly through the anastomotic leak, the bowel contents has leaks and patient has leaked into the local or generalized fecal peritonitis. That might be the reason. So the patient, in the question, it has not mentioned patient has had the defunctioning loop ileostomy. So the possibly the surgery has been done without a loop colostomy. So yes, we do that sort of surgeries when the peritoneal anastomosis is above the peritoneal reflection, and if we able to have good bleeding margins, sometimes we plan to do the anterior resection without defunctioning ileostomy. So that is the picture in this question. So there is anastomotic leak. So they are asking what is the next investigation to come to a diagnosis, right? So the patient seems to be a bit hemodynamically unstable with this condition. Okay. First thing is colonoscopy given as an answer. The colonoscopy is totally out because we have to insufflate some sort of air. Even sometimes, even a very minute leak, sometimes we might not be able to see a hole in the mucosa. Sometimes it can be a very small leak, which can give rise to pelvic collection, deep pelvic collection. And the other thing is when you're insufflating air, we can worse the condition. We can worse the condition because if there is a leak, we can increase the contamination with that procedure. So with the maneuver, sometimes the anastomosis can be completely dehisced. So it is out. Then contrast enhanced CT. Yes, contrast enhanced CT is always, almost always there to diagnose a complication because the advantage in here in contrast enhanced CT, we can do it with rectal contrast, giving rectal contrast. So in the CT, we can see if the contrast is leaking into the peritoneum or the the pelvic cavity. So we can confirm the diagnosis. At the same time, we can assess several things in contrast enhanced CT because Pneumoperitoneum, which we are going to detect in a erect chest X-ray, even can be there after 5 days time because the surgery can be done in laparoscopic or open surgery. So some sort of peritoneal air can be there. So the pneumoperitoneum or the peritoneal air can be there. So the erect chest X-ray might have air under the diaphragm. So it simply doesn't exclude a bowel leak or the anastomotic leak or established a diagnosis of anastomotic leak. So, but in the contrast enhanced CT, giving rectal contrast, we can confirm the diagnosis of anastomotic leak. At the same time, we can say that the patient might be having some pelvic collection also with with the CT. We can identify that, and so that sort of a detailed thing we can take through the contrast in a CT, but not in the erect chest X-ray. Laparoscopy, we have to give general anesthesia to this patient. So it is not a diagnostic modality here. And peritoneal tap is here, it is totally out because sometimes it can be a deep collection in the pelvis. So at least we have to do ultrasound guided, but however, it is not indicated here. So to diagnose, what is the next investigation to come to a diagnosis is, I think it is the contrast in a CT because we can confirm our diagnosis with that. But even with that, if it is a very localized collection there in the pelvis, in the contrast enhanced CT, we can do guided aspiration even. But the patient seems to be unstable with the features of sepsis. But still it is recommended to have, if it is a localized collection, we can do a guided drainage, or if it is generalized peritonitis, because the significant abdominal tenderness is there in the lower abdominal area. So lower abdominal area means seems to be with localized collection. So we can confirm the diagnosis contrast enhanced CT here. It is a bit of tricky question in between answer B and answer C. But to best investigation for the thing is to have a contrast enhanced CT with rectal contrast. Right. Then we'll move to the question 24. A 65-year-old patient with hypertension and diabetes present with abdominal pain, distension, and constipation for 3 days, and fever for 1 day. I have highlighted it in red color. And he was found to have obstructing carcinoma at the rectosigmoid junction. What is the most appropriate management option for him? Right, in this type of a case, actually, now the patient, the rectosigmoid junctional cancers are the cancers that which easily can give rise to complete obstruction because that is a relatively narrow part in your colon. So, can easily get obstructed. And the thing is, abdominal pain, distension, constipation for 3 days, and fever for 1 day. Fever for 1 day means some significant thing. Even though in bowel obstruction, the patient, if the patient has developed fever, then we have to think about that, especially in this situation, right? Because if the fever is there, some sort of sepsis may be going. So it can be due to two reasons. One possibility is tumor perforation at the site and giving rise to localized collection in the peritoneum. The other possibility is due to the significant bowel obstruction, the bacterial translocation can happen. So due to that, the patient can develop fever. So the both possibilities are there, but I think it is more towards sometimes it can the tumor can perforate and can have may have a pelvic collection there. Right. The question is, what is the most appropriate management for him? Now, in so rectosigmoid cancers are also considered as the rectal carcinoma. In the rectal carcinoma management, before the management, we need proper staging of the cancer. And patient definitely need neoadjuvant chemoradiotherapy before the surgery because the local recurrence rates are minimum with neoadjuvant chemoradiotherapy rather than upfront surgery. But here the situation is bit different because it is a typical presentation in a surgical casualty. This type of patients sometimes you may have met with and sometimes you may not. But however, it is fairly a common scenario to present with rectosigmoid junctional cancers present with bowel obstruction. Right. So the most appropriate management option for him, considering all the above factors, One is colonic stenting. Yes, colonic stenting is something that we can do, but here, if the patient is having fever for one day, as I mentioned earlier, it can be a perforation and localized collection, or the peritoneal contamination or bacterial translocation. So in this situation, it is a bit tricky to go for colonic stenting because stent might not relieve the peritoneal contamination here, but it can reduce further contamination. But it has already something has leaked into the peritoneum, so it might not uh, be the best uh, treatment option for this patient at the moment. Right? Elective anterior resection after optimizing. Okay, now elective anterior resection after optimizing means we have to build up the patient, nutritional the optimization, and then giving neoadjuvant chemoradiotherapy, proper staging of the tumor. So with the CT, and then for all of that, we need much time for that. So the elective anterior resection after optimizing, yes, it is a good option, but not here because the patient is in complete bowel obstruction with fever. So something is going on. We might need to attend the patient immediately or in an urgent way because the patient because of this condition mentioned in the question, right? Then Hartmann's operation. Yeah, Hartmann operation is we are commonly performing Hartmann operation. Hartmann operation is we can resect the tumor and resect the tumor out, and then distal stump or the distal rectal stump we can oversew, and we can keep it in the pelvis, and then we can take the proximal part of the bowel after the resection. After resection with adequate margins, take the proximal part as an end colostomy. So why we are not going for a anterior resection here, in proper anterior resection here, is because the proximal part of the bowel is dilated. So the dilated bowel is not very good for anastomosis, primary anastomosis, because the anastomotic healing rate is very poor in dilated bowel. So it is not an optimal situation, optimal condition, optimal situation for a primary anastomosis. So Hartmann operation is correct here, and it is a valid or the patient would benefit from Hartmann operation here because Hartmann reversal can be done later. So the patient can have the complete the bowel continuation without a colostomy. So the reversal can be done later. So in this type of a case, the good bailout procedure we have to offer, or the damage control procedure we have to offer. The best damage control procedure we know in this type of a case is Hartmann operation. Then loop colostomy and tumor resection. It should be colostomy. Loop colostomy and tumor resection. Yes, that is also can considered here. Loop colostomy if the patient is having rectosigmoid junctional cancer, we can do a sigmoid loop colostomy here. If the loop colostomy, and then we can optimize the patient, and then after the surgical after the tumor staging and the neoadjuvant chemotherapy or chemoradiotherapy, we can go for a tumor resection. But here, due to this fever for one day, so that is a bit. Then the patient's condition become a bit severe because some, as I mentioned earlier, that sort of complications can be there: tumor operation or bacterial translocation. So then loop colostomy and tumor resection is not a good option here in this patient. Then image guided drainage, if tumor has perforated into the abdomen, yes, we can do image guided drainage, but it doesn't solve, it doesn't going to provide adequate relief for the patient's obstruction, bowel obstruction. And even though we drain the collection, it is continuously, it's going to collect there. So it is not a good option here. So the Hartmann operation is the option in this type of a patient. That is the question, answer for question 24. Right. So then we'll move to the question 25. 40-year-old woman presented with episodic painless bleeding with mucoid passaging of stool. The appetite is normal and no weight loss. What is the most likely diagnosis? So she is a fairly young female and then presented with episodic painless bleeding and mucoid passage. So the painless bleeding, so it means that it is above the dentate line. The pathology is about the dentate line, so it can be from rectum most of the time. And mucoid passage. Mucoid passage. So the mucoid passage is there. Then most of the time the adenoma, the villus adenoma, or sometimes the mucinous adenocarcinoma can present much amount of mucin with that. So then that is the time where the patient present with mucoid passage. And the appetite is normal and no loss of weight. Appetite is normal means it is not seems to be an advanced cancer or something which give rise to the liver metastasis, which can lead into loss of appetite, or sometimes very advanced cancer due to the cancer, immune reaction to the cancer itself can develop loss of appetite because of the cytokine in our circulation can develop loss of appetite. But it seems that it is a very early lesion or something. That is the idea behind this loss of appetite, normal appetite state. And no loss of weight means it is not something very advanced. So then what is the most likely diagnosis? So chronic fistula. If the fistula is there, so the patient should have the perianal discharge, or sometimes continuous perianal discharge, or something has to be mentioned in the question. So it is wrong answer. Sigmoid diverticulosis. Sigmoid diverticulosis also can present in this type of a case, but not diverticulosis. It should be diverticulitis, because bleeding is not a feature of diverticulosis. So the answer is therefore wrong. Then first degree rectal prolapse. First degree rectal prolapse, yes, with rectal prolapse, this type of a thing can happen. So the bleeding and but not the mucoid passage, but bleeding can happen with the first degree rectal prolapse, but not mucoid passage most of the time. So the picture can be there in various situations, but it is not the typical picture for this type of a question, this type of presentation. Rectal prolapse, the same thing, and the villus adenoma of the rectum is the answer here, because villus adenoma can produce much amount of mucin, and the painless PR bleeding can be also there. So it is most of the time it happens above the dentate line. So it is the answer. The answer is E. Right. We move to the question 26. A 35-year-old female who has underwent a cholecystectomy presented post-op day 3 with jaundice and right hypochondriac pain. What is the most possible cause? So 35-year-old means fairly a young female. Cholecystectomy present on post-operative day 3. So post-op day 3, patient has developed jaundice. It's bit late, not in acute stage. So the most common thing in this type of scenario to happen is slip the stone into the CBD, because we do cholecystectomies for even sometimes symptomatic gallstone disease, sometimes after a episode of acute cholecystitis or gallstone related complications. So when we are clipping the cystic duct, we have to, as a habit, we have to milk the cystic duct with a, if we are doing it laparoscopically with a Maryland like instrument, milk the cystic duct back into the gallbladder, because the one or multiple stone can be there in the cystic duct. So when we are applying the clip without milking, when the clip, so it is a significant pressure over there, we are going to apply a significant pressure to the cystic duct. So stone in the cystic duct can slip in either way, even into the CBD or into the gallbladder. By when we are applying the distal clip, so the chance of without milking, there is a chance of slipping some stone or one or few stones into the CBD. So that is a fairly common scenario in laparoscopic cholecystectomy if you are not milking the cystic duct as a habit when you're performing the surgery into the gallbladder. So we have to milk back the cystic duct into the gallbladder. So this is a fairly common scenario to happen. And the thing is post-operative day 3. So it's a bit delayed. It's so after 72 hours means it has taken some time to develop this complication. So the jaundice and right hypochondriac pain means it is more. So the jaundice and right hypochondriac pain means the patient is in cholangitis. So it is now the CBD obstruction has to be there, right? So the thing that can happen in two ways. One thing is accidentally we can clip the CBD. So we can accidentally clip the CBD in laparoscopic cholecystectomy, even though now it is very rare, but still it can happen in the learning curve. So, but if it has happened, the patient might present bit early rather than this 7 to 2 hours delay. So even within 24 to 48 hours duration, the patient can present if we have clipped the CBD because it's total obstruction of the CBD. Now, if a small stone has fallen into the CBD, sometimes some bile can pass uh, into the duodenum at the surrounding area of the from the surrounding area of the stone, and when it completely obstructs the CBD, the jaundice develops. So it has taken some time. So the most appropriate answer would be escape the stone into the bile duct because clipped common bile duct should present bit early. Gallstones is a very unspecific answer. So I would take it as wrong answer. Stricture formation, it takes years to happen. So stricture formation is a possibility, but it takes years to happen. Escape stone from the bile duct and periampullary carcinoma is not the situation here because 35-year-old female, very unlikely to happen in that young age. So the underwent cholecystectomy. If the patient has developed periampullary carcinoma, you know that the patient will present very early with even with early lesions. They present with the waxing and waning type of jaundice. That is, the jaundice doesn't come to a baseline. So the jaundice will uh, so the condition can worsen and condition can relieve with time, but not touching the baseline. Not touching the baseline. Now the liver functions would not come to the baseline. So the ALP, gamma GT, and the total bilirubin levels would not come to the baseline in periampullary carcinoma patients, but the periampullary carcinoma is some lesion which present very early because the sphincter of Oddi, when even with a very small lesion, it can get obstructed. So the most of the patients can have surgery at very early stage of the disease, but it is not the typical picture here. So patient should present with jaundice to us usually when the periampullary carcinoma is there. So it is not the typical presentation here. So the answer is therefore escape the stone into the bile duct. So the answer is D for the question 26. Right. Question 27. 45-year-old woman presented with a 1.5 centimeter lesion in her breast for 2 months duration. Right. And which is suspicious of malignancy radiologically and clinically. So it is highly suspicious radiologically and clinically, and she has undergone two image guided co-biopsies. Two image guided co-biopsies occasional, which lead benign breast tissue. So unfortunately, it has the result is benign breast tissue. So what is the next appropriate step for the management? Right. In this type of a case, right, if the lesion is suspicious clinically and radiologically, so most of the time they turn out to be malignant. So then before when in breast cancer management, as I told you earlier, the golden word is triple assessment. So the triple assessment must be completed before any intervention for this type of patient. So here the answer should be, here the thing is, we need to have tissue diagnosis. So we need to have tissue diagnosis because it tells us much detail about the receptor status and type of the cancer before we proceed with the surgical intervention. So if it becomes negative two times, so again offering an image guided biopsy would not give a good answer, a good result for this patient. So in this type of, the ideal thing is we can do a image guided. So the image guided means via localized excision biopsy. So then we ask to put a wire into the area where you suspect. So it has to be done by the radiology team. Then we take the patient to the theater. The procedure can be done under general anesthesia. Then we are going to take the lesion out, and the wire will guide us. So we do it as a wide local excision. So take at least around 1 centimeter margin with the lesion, and then we are sending the lesion to the radiology room at the immediate post-operative period to do ultrasound scan or do a mammogram to see the lesion that you suspected is whether it is there or not in the lesion, and then we can send it to a pathology lab to confirm the diagnosis. So ideal answer should be in this type of a case wire localized excision. But that answer has not given in this the options here. But excision biopsy is a good option here because then we have to do a excision biopsy. It should be a wide local excision, not the excision biopsy actually. It should be a wide local excision. So it has to be yes, as I mentioned, it has to be a wide local excision. Not we are not performing excision biopsies in breast, especially in very rare situations. Right? So the image guided fine needle aspiration cytology. However, the cytology is inferior than the histology, so it is not the answer. Repeat image guided co-biopsy. Yes, we can do, but uh, why we waste our time for another attempt if when the two attempts has already failed? Then routine follow-up imaging in 1 year? No, no, not obviously. We can't let 1 year for that 1 year without any diagnosis for this patient because the patient is fairly a young one. And short interval imaging 3 to 6 months is still not possible because we don't have a diagnosis still in our hand. So ideal answer should be wide local excision or the wire guided wire localized excision biopsy. So the answer is not there, but the at least we can take answer A as the question, as the answer for this question, right? Then answer for the question 28. So a 42-year-old woman with a history of multinodular goiter for 5 years duration, present with an enlargement of the gland for 5 days duration. So it is the enlargement for 5 days. So it is relatively very short period. Then she is afebrile but complains mild odynophagia. That is pain during swallowing. So what is the most likely diagnosis? So in this type of case, or the fairly young patient with multinodular goiter for 5 weeks. So it has been tested previously with ultrasound scan to have not to have any suspicious areas possibly that implies with this statement. So then it is rapid enlargement within 5 days time. So the multinodular goiters, if rapid enlargement is there within 5 days time, it is very unlikely to have a cancer. Because if it has enlarged over a 3 months, 4 months period, then we can suspect there might be a transformation of some nodule into a cancer. But it is a very rapid enlargement. So this type of case happens when some one nodule is bleeding. One nodule is bleeding. So that is we call it as bleeding into a cyst. So when the bleeding is there, the acute bleeding is there, so the gland will enlarge very rapidly. So within 5 days time is fairly adequate for that to happen. And then the patients can develop dysphagia or sometimes not dysphagia or dynophagia with that because when the patient is swallowing, the esophagus might touch the gland, and then when you're pressing the gland over there, sometimes the patient can have pain on that, and then when the thyroid capsule is stretching, it develops pain. So the typical the presentation of bleeding into a cyst according to this question. So we'll move to the answer. So it is acute thyroiditis. Yes, thyroiditis also it can happen, but not in rapid with, but not with an enlargement. It's not possible within 5 days time. So bleeding into a node, yes, that is the answer. Malignant transformation, bit unlikely with the short period. Esophageal cancer, unlikely. And then subacute thyroiditis, unlikely due to this presentation because subacute thyroiditis even can happen, but not this type of odynophagia or rapid enlargement within 5 days time. So we are left with two answers, acute thyroiditis or bleeding into a node, but bleeding into a node is the most possible situation here because of this odynophagia and enlargement of the gland within 5 days time. Right. Then we move to the question 29. 37-year-old man presented with the emergency department following road traffic accident. And then on primary survey, airway and respiration is normal. So the airway breathing is okay. Then there is localized tenderness over the right hypochondriac area and his hemodynamic is stable. Fast scan shows free fluid in the hepatorenal. So now we have in the primary survey, in the assessment of circulation, the adjunct is the fast scan we can do in the acute stage, even in the primary survey, that is well accepted now. In the fast scan, it shows free fluid in the peritoneal cavity, and the patient has right hypochondriac tenderness also. So the most possible thing is to have a liver laceration, most of the time. So the next management, indicated management, angiogram and embolization. So even in liver lesions, yes, we can do, but not in this type of acute stage. So if it is arterial bleeding, yes, we can do embolization here, but most of the time liver, it is not arterial, it is portal venous bleeding, or the hepatic venous bleeding is there in the liver, so sometimes it might fail. So CECT abdomen. So the CECT, sending to a trauma patient into the CECT, is we call sometimes the CT machine as we call it the so the so we have to send the patient if the patient is only hemodynamically stable, because if we send a hemodynamically unstable patient to the CT, the patient might die inside the CT machine, right? So therefore we call it death of donut, right? Death of donut. So for the CT machine is like a donut. So the patient can, if hemodynamic unstable patient, if you are sending that patient into the CT, the patient can die inside the machine. But here it is clearly mentioned he is hemodynamically stable. So only with a CT we can grade the liver injury. So almost all the liver injuries, we don't need to go in and do any intervention for that. Sometimes the bleeding itself settles. So we just have to monitor the patient for about 48 to 72 hours period, but we must have 24/7 blood bank facility, 24/7 theater facility, 24/7 anesthesia facility, and 24/7 surgical facility should be there in a patient, if this type of a patient which we are going to monitor. And at the same time, the surgical intervention is not essential in all the grades of liver tumors. If the even it's a grade 1, grade 2 not the tumors, liver injuries, sorry, that word liver injuries, it is not essential to go for do a laparotomy and stop the bleeding or do the liver packing or liver repair. Sometimes some bleeders can spontaneously settle, so that whatever the blood in the peritoneum will reabsorb eventually. So we have to monitor the patient very carefully. So in that side of a situation, the CECT abdomen will give you great detail about the liver injury, what is the grade of the liver injury, and other organ injuries also. So in ultrasound scan, we can't assess the bowel, we can assess rest of the organ, we can assess the pancreas, we can assess the other organs also. But CECT abdomen, we can assess all the organs, all the organ in this acute setup, provided that the patient is hemodynamically stable. So I would think this is the best answer for this question. So the diagnostic laparoscopy, we don't need to give general anesthesia to the patient and do that type of intervention, because it is not needed here if the patient is hemodynamically stable, and if we can monitor the patient, if we can manage the patient conservatively without any operative intervention. So why should we go for a diagnostic laparoscopy? Then diagnostic peritoneal lodge, obviously some blood will come out, but we don't have any further diagnosis with that thing. We can confirm, okay, peritoneum has some blood, but it's still we are not left with any other options for that. So that is also out. Emergency laparotomy, not essentially each and every liver laceration. Some liver lacerations we can manage conservatively very successfully, provided that the all the facilities are there with us, and we have 24/7 monitoring facility for the patient. So ideally the patient should be in ICU, the solid organ injuries. if you are going to manage it conservatively, right? So for the decision to take about conservative management will depend on the patient's hemodynamic status and the CT findings. So I think the management here is, if since the patient is hemodynamically stable, the CECT abdomen. Then the question 30, 20-year-old man had trauma to the groin region. At that time, there was no bleeding and he was able to walk. Following day, he has developed progressive increase in lower limb pain and weakness. At the time of presentation, lower limb pulse were absent and he was unable to move the limb. What is the most appropriate management? So, what has happened in this question, in this scenario? So, trauma to the groin region means, so the no bleeding means, so it is a significant contusion there to the soft tissue. So the groin region, the femoral vessels are in danger. So you can have a contusion or the intimal damage in the femoral artery. So the thrombus can slowly develop in the femoral artery. So that is the most possible. That is the highest possibility. So because at the time of injury, the patient was able to walk even. So when there was no bleeding and patient was able to walk, even though a thrombus developed, immediately the patient doesn't. The patient it doesn't develop into a significant neuroischemia for the patient to make the patient disabled. So it takes time. So here, what has happened was actually with this groin trauma, with the soft tissue injury, the blood vessels, the intimal damage might be can happen here, and then with that, slowly a thrombus might develop. So then when there is a complete occlusion to the blood flow, so then it develops to develop, and then it is time to develop the ischemia to the muscle and ischemia to the neurons. So when there is ischemia to the muscle, it produces significant pain, right? It produces significant pain. That is disproportionate pain. So disproportionate pain means the pain is not proportionate to the injury. So at the time of injury, ideally the maximum pain should be there. With time, the pain settles. So, but after some time, if the patient develops pain not even related to the primary injury area, then we have to suspect of some sort of even sometimes ischemia or compartment syndrome. Due to the ischemia, the muscle cells and the compartment syndrome can develop. Here, the problem is due to this complete cutoff of blood to the limb, it can lead to neuroischemia as well as the muscle ischemia. So, due to the neuroischemia, the patient will develop paralysis with time. And then due to the muscle ischemia, the patient will develop pain, and after some time, also the muscles will stops its work or the contraction. So the patient can have paralysis. So here sometimes you might know there is a classification called Rutherford classification in acute limb ischemia. So this is a scenario about acute limb ischemia. So there is a Rutherford classification for that. So in Rutherford classification, if the limb is the paralysis is there, at the same time complete anesthesia is there, not the paresthesia even, complete anesthesia is there. It is just a scenario about a dead limb, right? So then it implies that the limb has already died. So then in that type of a situation, it is essential to go for amputation. But this question is a bit tricky because it has not mentioned lower limb pedal pulses were absent and it was unable to move the limb. Yes, unable to move the limb, but they have not mentioned about the what about the sensory status here. So some paresthesia might be there. Sometimes the sensation can be there or not. So they have not mentioned. And the patient is 20-year-old. They are a young one. So we must uh, try our best to preserve the limb. But however, in almost always, life is before the limb. So if you are going to perfuse a dead limb, the patient will definitely die. Why? because the blood will going to go through the dead tissue and all the toxic material will release into the circulation. That is called the reperfusion injury. So with that, the patient can go into a cardiorespiratory arrest immediately. Immediately. Therefore, we must not perfuse the dead limb, but at least we should try to see whether the muscles are viable or not. For that, what we can do is we can do a fasciotomy and see whether the muscles are viable or not. If if after a fasciotomy, if the muscles are not viable, we are not going to reperfuse. We are not going to do any vascular intervention for that. Then the patient warrants amputation for that. But before that, at least we should confirm whether the muscles are viable or not. So by doing a fasciotomy in the calf region, so we can by putting two incision or sometimes even by putting a single incision, we can assess at least two out of three compartments are not viable. That is, then amputation is indicated here. So the question is a bit tricky. I think the fasciotomy is the answer. If after the fasciotomy, if the muscle seems to be not viable, the answer is amputation, right? So thrombectomy, we are going to reperfuse the limb. So before assessing the limb viability, it is not a good option to do a thrombectomy because if we are going to perfuse a dead limb, the patient will die because of the reperfusion injury. Then fasciectomy, there is nothing called fasciectomy. So fasciectomy is complete excision of the fascia. So it is not a good option here. I think it is the wrong answer. Then angiogram is not indicated here because it is a acute limb ischemia. It is Rutherford grade 3 is almost Rutherford grade 3. So angiogram is not indicated only in Rutherford 1A, 1 or 2A. You can consider uh, angiogram to have the diagnosis, but then the patient should have some movements in the lip. Only pain might be there with absent pulses, but not complete anesthesia or complete paralysis. So the paralysis is there. That means that the patient is having significant neuroischemia and muscle ischemia. So the patient needs immediate intervention because time is muscle because time is muscle. If you are taking your time, that is so the patient has to the suffer with a ischemia into the muscles and nerves. So time is muscle almost always. So you have to act very immediately. We don't have time to go for angiogram in this type of a case. So I think the answer for that is fasciotomy and see the muscle viability. So here today we have discussed 10 single best answers in a very short session. So I think sometimes you might have some the queries with this discussion. So you can put those questions in the comment section in our YouTube channel, and then we'll meet another session within very short time to discuss another 10 or 15 questions in single best answers. Okay, until then,